Dr. Bauer, you can start.
Yes. Good evening, respected Founder President Glanivelu sir, President Amasi Varghese sir, Secretary Deborsi sir, Past President Jugindra sir, Secretary College of Amasi Tamonas sir, Biju sir, all our EC and online viewers. Good evening to all. Today is our Merrill Amasi CME, and the today's topic is virtual, augmented and mixed reality in surgical practice, the hype and the hope. And for this, I invite our President Amasi Varghese sir for welcome speech. So now over to Varghese sir.
Thank you, Dr. Banwar Yadavila, for the online CME Amasi is happening every first Thursday at 8 p.m. Indian time. And apart from this, we have another online program where the surgery demonstration is being done. That's on every third Thursday between 3 p.m. to 6 p.m. And today we have a very eminent speaker, Dr. Shridhar Ganapathi Iyer. Sir is from India but settled in Singapore and working as HPB group head of NUH National University Hospital Singapore, and also the president of Transplant Association and various other responsibilities. We are happy that you are here today to share us on the topic that is going to be the future of the surgery. And then apart from that, we have an expert panel of moderators, Prabha Madam from Jaipur, and Dr. Prashant Rahate from Nagpur, and then Rajendra Madi again from Jaipur. And we are sure that today's both the talk as well as the discussion is going to be excellent. And there will be the usual quiz program, which will be done by Dr. Boshi. And we are also very close to our annual conference of Amasi, that is AmasiCon, that is going to happen in Hyderabad between 15th August to 18th. So I also welcome each one of you for that mega event. And if you are not registered, please make the plans for AmasiCon Hyderabad, which is not very far away. And I also take this opportunity to thank Merrill, who will be continually supporting Amasi educational programs. And once again, welcome all of you for this CME program. Thank you very much, and over to Dr. Bauer.
Thank you, President sir. Now I invite our Secretary Deborsi sir for the first quiz question. Deborsi sir.
Right, as the topic is regarding some augmented reality, the first question is on visual AR display technology. What is the optical see-through device? You need to name A, B, C, D, any of them, and send it in the link. This will be visible for 2 minutes, and in the next 5 minutes, one can answer this. This is open to young faculty and residents all across the country and the nearby countries where this is being transmitted. This carries a prize of 5,000 Indian rupees, and this will be given to you if you are an Amasi member, and provided you win it. The fastest finger first wins it. Right. Bhavar, I think this can be displayed and you can go on with the program.
Yes, sir. Sir, today's the panel...
Bhavar, just to say that the second quiz will be just after the lecture, before the discussion starts.
Yes, sir. So, sir, the today's panel of moderator are Dr. Prabha Om Madam, Professor and Head Department of Surgery from SMS Medical College, Jaipur. And second moderator is Professor Rajendra Mandia, who is also former HOD and Professor in Department of Surgery, SMS Medical College, Jaipur. And third moderator is Dr. Prashant Rahate, who is Director of 7-Star Hospital, Nagpur, and laparoscopic surgeon as well as coloproctologist. So now I request Prabha Madam to please introduce the today's speaker, Dr. Ganadipati sir. Now over to Prabha ma'am.
Good evening, everyone. I welcome Dr. Shridhar Ganapathi Iyer. He is Senior Consultant Group Head, Hepatobiliary Pancreatic Surgery, National University of Health Sciences, Singapore. Co-Director, National University Center of Organ Transplantation, Singapore. Visiting Consultant, Singapore General Hospital. And President, Society of Transplantation, Founding Member, Past President of SPPA, Associate Professor, Surgery, National University of Singapore, Member, Joint Committee on Specialist Training, Singapore, Joint Committee, Panel Site Accreditor, Singapore, Program Director, General Surgery, National University Hospital. He has many degrees to fellowships to his credit, and he is the founding member of Hepatobiliary Association of Singapore. So, welcome, Dr. Shridhar, for your talk.
Thank you. Thank you very much for the kind introduction, Dr. Prabha ma'am. And very good evening to the esteemed colleagues and panelists from AMASI. And a warm welcome to all the participants. It's honor and a privilege to present on this topic. I'll just start to share slides and let me know if there's any issues. The concept of virtual and mixed and augmented reality is not really new. It's been there for decades, even before the 1990s, but it has caught the medical field in the recent past. So to start with, I have no financial disclosure. All the work that is presented represents research and development and work in progress. All the studies are conducted under approved ethical standards and relevant review boards. I have personally created some content for Kaleo. It's a VR surgical education company. And most of the applications that I'm going to discuss are mixed reality based using HoloLens and Apoclar. So if we look at the evolution of surgery, I think what we are increasingly seeing is the decreased ability to make clinical decisions. There's increasing difficulty with open surgery there, especially depending on where you're trained, especially in the United States, that's a big problem. Lack of ability to read 2D scans. Again, the more time you spend reading scans, the better you get it, because what you're looking at in 3D format, your brain has to process that and create a 3D image so that you can operate safely. What we will see in future is probably more precision in surgery. And we do see publications looking at less open and close, more R0 resections, less blood loss. Increasingly, we are seeing operating with AR, VR, MR, 3D holograms, and eventually probably operating with robotics. When I say robotics, I don't mean the Da Vinci, because it is a completely controlled system. But when I mean robotics, it is more of some degree of automation of action. So the concept of all this mixed reality, virtual reality, I'll just discuss briefly. Virtual reality places the user in another environment entirely, and that is either real or computer generated, but the user doesn't see anything else other than what is being displayed in front of the eyes. Augmented reality, it started with Google Glass, or there was Yelp app's monocle feature. So what happens is on the visible natural world, you overlay some images, and that image is a digital image. And finally, mixed reality is basically a situation in which the virtual objects are integrated into the real world, and you are able to control the virtual object and manipulate it. So that's mixed reality. And some devices are a combination of all these features. So again, this is just a futuristic video. It is not a real life application, but really what we are looking at is everything that is there in front of your eyes on the screen, but you don't see the natural world, and very basic form of reality. Now, just before the talk, I created this augmented reality just to tell you what the concept is about. I placed a heart in the study room here and then rotated it around. So it is useful to study anatomy. And this is a easily available feature. And of course, this is a heart that you can do the anatomy study for liver, pancreas, name the organ with disease, without disease, normal anatomy. So this is augmented reality. So what happens is there is a human being which interacts with the environment is conventional, our own reality. When a human interacts with computer, that is a computer and human interaction. When the environment interacts with computer, there is a perception. But when we look at the intersection of this Venn diagram, that's what mixed reality is about. Now, with regards to augmented reality in surgery, it is useful for surgical planning, surgical education, visualization, surgical manipulation, and it is a controlled environment. Again, this is a very early development from University of Toronto, just teaching the anatomy of liver and the biliary system. And the user can manipulate these organs, take out the liver, just look at the images of the right lobe or left lobe, just look at the vessels, look at the bile duct individually. So a lot of things can be done. And of course, these images can be moved out, moved in, and integrated together. So just playing with it gives you a sense of your 3D anatomy and learn faster. With regards to limitations, there is lack of situational awareness. There is a lot of these devices come with control dongles, which are not very user friendly, and it is not useful for on-table use when it comes to surgery. Now, I have come across at least 13 companies which have listed, which are doing various form of development of mixed virtual reality and robotics and AI for surgical practice. And some of these companies I've named. You can take a snapshot and then look up these companies. What I did was I did create some content for this company called Calio. It is the most basic form of virtual reality for surgical education, and the content was created which is you put in a mobile platform. And this mobile platform, when you look at it, the surgery, you can see because it is created in 3D, you see two images. The environment is also mapped using a 3D camera. So when you put this mobile phone in a VR device, you can also look at it in a 3D format. And then you can turn your head one side, you can see the operating room. You turn the head to the other side, you can see the picture, this surgical procedure. So useful for learning, because normally when we look at these videos on YouTube, etc., there's a lot of limitations because it doesn't give you all the content you need. Doesn't tell you where the ports are going. Doesn't tell you where the anesthetist is, where the scrub nurse and the tables are, where the um, assistant is standing. So it gives you a good 3D mapping of the entire environment. So again, this is one of the cases recorded for virtual reality platform. And again, it's a 3D recording, so you see two screens. So I'll just fast forward it. But what I'm coming to is I give you an example of a right appendectomy with the anterior approach with a diaphragm resection for a case also recorded for this purpose. One of the limitations of using this YouTube videos is basically it doesn't tell you much about the patient. It only shows a very heavily edited clip. It doesn't tell you what happens to the patient post-operatively, what is the histopathology. Also, it doesn't tell you what the surgeon position is, what the assistant position is, where the ports are placed. Suddenly you look at the YouTube video and you want to do the case, it's very difficult to sort of replicate it sometimes. So to overcome some of these problems, we said, okay, let's create something which we can make it useful for the audience. And again, this is part of the operating now. Let's say if I want to really see what is happening on the laparoscopy screen, then you monitor, you turn the camera around. You want to see where the assistants and the surgeons are standing, you change. You want to see the port position, you can zoom in. So it is easier to learn and easier to appreciate what's going on with the VR platform. So again, I won't go through the entire case because it is in 3 parts and each of these is about 15 minutes. So we'll finish 45 minutes just looking at this. So it's just to give a flavor of what is possible with VR. And again, you put this phone in a VR device, which costs not more than $10, $15, and you can lie down in the bed and watch the video and then learn. So there are many of these. Of course, some are very expensive. The Oculus company's VR devices are more expensive. What I was talking about is a very cheap device, but the more expensive, of course, the more functionalities it has. So if you look at the market size for the VR devices, it's growing at a 45% CAGR growth rate, and probably estimated to be about $25,000 million in about 4 or 5 years time. So what I have here is a HoloLens 2, which is what has been used in our institution quite frequently. Again, quite a complicated device with several cameras, head tracking cameras, RGB depth camera, and all that. Similarly, Apple Vision Pro was released later on after the HoloLens, and it is also has similar capabilities, and of course, they do claim to have a much better chip. So our whole medicine program leverages on mixed reality. It is to enhance clinical capabilities, improve the clinician experience. Obviously, the ultimate goal is to improve patient outcomes and also surgical training. So in terms of surgical education, now when the residents are introduced to anatomy, they are looking at these pictures in Saviston, Schwartz, the textbooks of surgery. And it is all in 2D format, unless that person now has to go to anatomy lab or cadaveric dissection. Again, there the color of the tissue is different depending on how the body is kept. So you can use these plates and images and then create a anatomy tutorials and lectures, and at the same time have real anatomy. Now, of course, this is not a patient. This is a patient. This is a donor scan, so it will be normal. But what I would like to show is the people can appreciate a 3D anatomy instead of what they see on 2D. Now, 2D, the image is showing the posterior aspect of the liver, a bare area of the liver. Again, you can turn the liver around and see how it looks like from behind, and where the IVC is, where the aorta is. You can also see whether there is any variant anatomy. You can overlap the image with the textbook images, and it is easier and faster to study that way if these tutorials are created. So currently we are testing this among residents to see how their learning improves with a knowledge of anatomy given with a 3D format versus conventional education where we teach anatomy. If there is opportunity with cadaveric dissection, otherwise it is just a classroom teaching. So useful for preoperative planning. This is again donor anatomy scans, where we are taken out the liver parenchyma, just looking at the portal vein, hepatic veins, and the hepatic artery. Of course, you can have colleagues who are remotely located also to join in the discussion, and plan what kind of resection we are going to do. Take the middle hepatic vein, how many outflows to reconstruct. If we are not taking the middle hepatic vein, how many inferior hepatic veins are there? Of course, the technology also allows you to look deep inside and then turn the images around and appreciate it much better. You can also have the avatar of the surgeon or the colleagues who you are discussing the case with. Here is the avatar of another person. He is actually not a surgeon, but from Apoklar, CEO of the company, who's manipulating the images from a remote location. He was in Germany, we were here in, so that's why it is dark outside, evening time for us. So interactive discussion can be held, and you can have a slicer box to look at the anatomy in detail. Useful for preoperative planning when there is more complex tumors. This is a big colorectal liver metastasis. We again did this to look at how closely it is applied to the middle hepatic vein, because there was a doubt that it was either touching it or involving it. The right hepatic vein was clearly involved in this case. But this sort of gave us, I mean, experienced surgeon, it doesn't help that much, but for people who are earlier in their career, it is more useful. Now here you can appreciate that this patient has a big inferior right hepatic vein, and the right hepatic vein is completely involved. And the middle hepatic vein, although it is looking close, looks like we can get away by not taking it, and yet get a nearly R0 resection. And because there's a big inferior hepatic vein, obviously this patient can, instead of doing a full right hepatectomy, you can spare the inferior segment 6. We also use it for intraoperative image guidance. This is a laparoscopic retrieval of left lateral segment for living donor liver transplant from adult to child. Again, for experienced transplant surgeon, it doesn't really help that much. But let's say you have residence trainees, you put this image, you'll tell, okay, segment 4 veins, while you are cutting along this direction, this is where you'll get this. Segment 4 pedicle will come here. This is where the left hepatic artery is, left portal vein is. So easier to appreciate the anatomy during the surgery. And of course, the idea is because you are having less clinical material and more people to learn. And of course, there's a limitation of duty hours in all over the world. What we used to spend about 100 hours per week, now they're restricted to not more than 80 hours per week. So obviously, they have to learn more in a shorter time, and we didn't have that many laparoscopic surgery. It was just coming up in our time. But now they have to learn not only open surgery, laparoscopic surgery, robotic surgery, much more to learn, much shorter time and less time. So again, there are some gains in doing that. Now, intraoperative image guidance, as far as 2015, there was a publication from Japan, which talked about it. And basically here it is an open surgery. All the patients underwent this CT scan, and the 3D reconstructed images were created using imaging software. And before surgery, there was an initial pair point matching registration performed using the anatomical landmarks of visceral organs using a pen probe with infrared diode emitting diode markers. And then what happens is the margins of the soft tissues, blood vessels were used as a registration fiducial point. And the operative field was captured using a rigid stereoscope. The real-time operative field and the images were overlap. So easily, I mean, this is what it looks like from a surgeon's viewpoint when they used polarized glasses. The problem with this is that it is to help decreasing the margin positivity rate, try to get more accurate resection. Intraoperative ultrasound for most people works as well. So is there a very added benefit? I'm not too sure, but the problem why it didn't take off on a big way is because the amount of equipment you need to do this. But whereas with laparoscopic surgery, it is much easier. Whereas with open surgery, you need special cameras. Now with lap surgery, you don't need that. Now that has become easier with the HoloLens, because now let's say this is a pelvic paraganglioma which was undergoing re-resection. So second time surgery in a place where it has been operated before. It is a small tumor, and instead of digging into various planes and different locations, it get bleeding, and then more and more difficult it becomes to track where it is. The PET scan was overlaid onto the patient's abdomen and say, okay, this is where it is located. Of course, you have to match the iliac crest and some anatomical landmarks so that the overlay image fits into the patient's abdomen. So using this, it is easier to locate the tumor. Of course, this is a pelvic paraganglioma. I am a liver surgeon, HPB surgeon, so I have also certain application for it. I used it for colorectal liver metastasis. There's a previous publication on that using similar approach, but this was for open surgery. I used it for laparoscopic surgery. Use the image to show, because one of the problems with colorectal mets is after chemotherapy, they disappear. So sometimes you use the preoperative imaging before the chemotherapy, and then okay, these are the small locations of the tumor, and then you can overlay the images and at least go to that area and take that out. So again, in neurosurgery also, there is this application of intraoperative image guidance, not particularly relevant to the current audience. We have also used it for rib tumor localization and resection, which is not palpable. The MRI scan was overlaid with the patient's chest. Again, the fiducial markings were sort of overlaid, sternum, the clavicle and all that, so that the image is matched, and the rib tumor was accurately located, and it could be taken out with a small incision and removed properly. We also used it for graft reduction in living donor liver transplant. So again, sometimes when we operate babies, do transplants for children which are less than sort of 1 year old, then we need to see whether the liver will fit in, and if not, we can reduce the graft. Now, many times the grafts are thick. There are two types of livers, left lateral segment. Either they come in a thin form, which is called a flatfish form, or they come in a very thick form, which is a blowfish type. So we need to decide whether you need to reduce the liver on the lateral aspect or the anterior-posterior aspect, or both, ideally both. So now we know that this liver won't fit in the abdomen easily and needs reduction. So this is a patient in whom we did open surgery, reduced the liver, and then after reduction in two directions, the graft was then implanted successfully in the child, and this is the portions which were reduced, and this is after implantation, where the child's abdomen could be closed easily. So again, one more case we just did day before yesterday of a living donor transplant and graft reduction in two directions for an infant. So one of the issues, the physical things that need to be happening for superimposition of digital and surgical field is the ability to get a proper calibration. You need the cameras to track, and also you need registration points. Now, one of the holy grails of intraoperative image guidance is tissue segmentation and deformity models. Now, to put it simply, it is easy to do navigation for rigid structures, bones, cranium, skull, easy, because the rigid structures don't change. Whereas for soft tissue, It depends on, you do a head up, head down, there'll be change. If you look at the liver, patient is, fluid overload, fluid underfilled, the volume of the liver may change. Moment you put the laparoscope, take down the ligaments, change the direction of the liver, it will change. So the problem with this deformity modeling is that it's very difficult because it needs a lot of these physical properties to be taken into consideration before you can create that. The shear stiffness, storage modulus, loss modulus, damping ratio. And all this I learned only when talking to engineers, because we want to create a model of the liver where if I lift the falciform ligament and the liver stretches, the model that we have created also will stretch. And that's what we want to do. And that will give us real-time navigation. The other problem with navigational surgery is when we draw cutting planes on the liver, it is always a straight plane. And you know that sometimes you have to curve the plane. Even with anatomical resection, segment 6 resection can't be one straight line. There will be one line here, one line there. So we now have started to create deformity modeling where the planes can be shifted. Now this is a tumor, and we can move the mesh points on that plane so that you can curve around the tumor. And now I know that I need to take out this much volume of liver, and what will be the remnant, it is easier to compute. And also how to get good margins. So we are creating this shape-shifting deformable mesh for augmented reality, which will allow us to plan in 3D. So currently where we are located is we have moved from the 2D imaging modalities to 3D imaging using virtual reality, augmented reality. But the holy grail is navigational surgery with deformity modeling. And of course, the final goal will be AI real-time navigation. So that's where we need to reach. I've used this for donor counseling, patient counseling sometimes. And of course, you need to have time in the clinic. And this is a donor who's trying to understand his own scans. And they read a book, information booklet about complications and risks of surgery. They come into the clinic. I don't need to explain everything. I just show the images. This is where we are going to go cut and do. And of course, I go through the principles of this complications, what can be expected. So their understanding of the problems become much easier. When I say bile leak, when I say bleeding, when I say, liver failure, their understanding becomes better because they understand this much is coming out. This is where the bile duct is. This is where the problems are. We use it for global collaborations or outreach programs. Now, this is a case of a cholangiocarcinoma, hilar cholangiocarcinoma, which we had a discussion of, along with other topics of future of AI in surgery and things like that. But a case-based discussion with experts across the world to talk about what kind of resection to be done and what to take care of, where to drain, things like that. So also another video showing global collaborations where there is avatar of a surgeon coming into the field who can manipulate the image and also talk about the patients and the condition. We recently, after the IHPBA meeting in Cape Town, some of my colleagues went to Ghana, and we decided that it's a good opportunity to do some basic work, but also have remote assistant possibility. So there was a colleague sitting in Singapore and discussing with the surgeon about the surgical, and also could draw lines, annotate, and show what tissues, what structure to expect where, so that we can reduce the complications in surgery. Of course, there were people there also. Now, one of the advantages of this project was when we started out, the telecom system was very poor. And without a good network, it is very difficult to do a live sort of communication. But when we said that this is a project for human development and medical development and things like that, the telecom companies started getting interested, and they actually put in extra towers and things like that. Of course, that will be a much better use of the technology. But what I'm saying is, investing in this, remote telesurgery has improved communications, which is useful for day-to-day purpose. Now, here is a surgeon who's doing rounds with the local surgeons as well as one of the members of the team, and across discussions can be heard. So we are not only talking about surgery, but you can talk to the patients, you can interact with the patient. Of course, you can't do a physical examination, but surgeon on site can do that. So extending the tertiary care to lesser accessible areas is what we were endeavoring to do with this. The limitations are cost, hardware and software infrastructure, training, and sustainable expert access. And of course, it needs time and effort. We also did this in postgraduate education, especially during the pandemic when half the team was not in the wards. So a lot of surgical residents will lose out on practical experience because they have been told to do only outpatients or only inpatients. So we do rounds with the resident wearing the HoloLens, and then we talk to the patient, look at the scans, and the resident sitting remotely can see everything that is going on in the ward. Of course, we have to take permission from the patients. Now, finally, some of the last slides. What we see in virtual reality, you can't touch. If you touch, you feel nothing because your hand is moving in the air. What if you can touch the organ and feel the organ? Now, why is that important? Is because then it makes the user experience more realistic, number one. And number two is the haptic feedback can tell you to some extent, that liver, for example, is not the same feel if it is a normal liver or if it is a cirrhotic liver or it's a fatty liver. Similarly, heart is not the same feel when it is a normal heart versus a congestive heart failure. So now the university has developed one haptic glove, which was showcased just this year in US computer science exhibition, and the surgeon wearing the haptic glove is feeling the heart, which is actually on augmented reality, and this heart, he can feel the pumping in the hand. So similarly, we are developing models for the liver, the real liver of the patient, extract the physical properties, and then embed that in that virtual reality. So when you wear the glove and touch that virtual reality object, you can also feel that physical properties in your hand. So we work in collaboration with various organizations, including Microsoft and Apoclar and University and IHBBA and the Holo Medicine Association. Of course, as surgeons and as doctors, we always want to ask for evidence. So far, the evidence has been very limited. The only evidence it has shown is there is beneficent effect of our medical education and at least non-inferior results when compared to conventional teaching. And the users demonstrated greater enthusiasm and enjoyment for learning. But as all things in life, when it comes to technology, there is an innovation trigger, there is peak of inflated expectation, there's a trough of disillusionment, and finally a slope of enlightenment. That's where we need to reach. And where augmented reality is here. It is very close to peak of inflated expectations. We'll see where things go in years to come. Now, finally, I would like to state that when we talk about anything in surgery, the main drivers of change is never evidence, unfortunately. And that's a big pain point. It is mostly drivers of change is industry, it is the social media and the media, it is the patient demands, it's the peer pressure, it is the health economics, it depends on the private versus public, it depends on funding, it depends on health economics, training, education, retraining for mid-career surgeons. So finally, I would like to state at a certain point in technology adoption curve, searching for evidence actually becomes pointless. So with that, I would like to thank everyone for the attention. The best way to predict the future is actually to create it, and that's what Abe Lincoln said. And I wish to thank the Holo Medicine team, my colleagues, Dr. Gao, Dr. Niam, who have been heavily involved in this. and the HPB and liver transplant team. Thank you very much.
Thank you, Dr. Shridhar. The excellent talk. The use of the VR and AR in the medical field. And what are the limitations for the VR in the surgical training?
The limitation is mostly the cost at the moment. Number one. Number two is the content needs to be created. And there are many companies trying to compete for this space. And unfortunately, where there is a lot of content, that's where the content needs to be created. There is a lot of content in India, much more than what Singapore has, very clearly. So that's where the content needs to be created. Once the content is created, and then people should start looking at YouTube for these videos. Web search is the other platform, but again, not that widely available, or not that widely used also. So if you create the content, it is. So the company which I work with, they have about now more than 700, 800 videos now of various disciplines within surgery. And so once that bank is created, then it is okay. Now the device cost will come down over time. As the technology progresses, you are getting 5G network now, most of the places in the in the world, except for very remote areas in Africa and things like that. But with that, device cost will come down. But it's the content creation that is, to me, the biggest limiting factor. And also, it can't be used in the operating room. It is best used when you are sitting at home or you are not working, because the VR takes you in a different environment. And there are more expensive VR devices where you can wear it. It blanks out and shows you only the virtual environment, but you press a button, there is cameras in the VR device which shows you the rest of the environment. So it is also possible to use it at work, but more cumbersome. Yeah.
Good, thank you.
Sir, Mandya sir.
Yeah.
So I request Deborsi sir for the second quiz question.
I think, Bhamar, you can go ahead with the discussion. In between, we'll show the quiz. I think time will
Okay.
leave that way. We will
Thank
show
you.
the quiz on the screen. Discussion can go on.
Okay. So now again over to moderators for the discussion.
It's very excellent use of this technology. Recently, Dr. Parth Sarthi operated the JAM hospital. And he used the Apple Vision Pro and did the lab surgery. So it's a very good, excellent tool, and we can use in the teaching as well as in the training by using these VR and AR. It's a very good technology. So we have to focus on these things, and we have to develop the program where we can teach our PG postgraduate students about the how we can train them. So for both things is we can reduce even the complication, and we can get the better outcomes.
So it is good to ask the resident. Previously, in my younger days, people used to ask, you don't come into the OT without reading the Mengo's abdominal operations, right? Now you should say, read this textbook, you read the chapter before coming to the OT, but also see these videos, see 4 or 5 videos which are peer reviewed. They can't be any random videos. They have to be peer reviewed. And there's a good paper in surgical endoscopy with the title of Lab Vegas. It tells what are the content, what is the necessity, what are the minimum requirements for a educational video. It talks about patients, even if it is a 10-minute video, it needs to have patients' preoperative particulars, the scan. Then the key operative steps should be shown in the video. Any pitfalls and danger areas has to be described. It has to tell about the postoperative course. Of course, intraoperative positioning, anesthesia, what positions should also be the part of the discussion. and finally what happened to the patient and what is the histopathology of the report. That there is a minimum standards for reporting, and if you have the minimum standards, then we can, the content should follow that protocol.
Even we can use the VR technology to just educate the patient and their relatives.
Oh,
So
yeah.
explaining the how the used
Hmm.
show on your slide also how you educate your patient and their relatives, what complication can be occur. And that's very good thing by which we can reduce in the lot of litigation and legal issues is if you well explain to patient what we are going to do, what complication can we occur on these things. So it's very good. It's a nice the use of the technology in the surgery, especially in for the training and for the education purpose. So
Dr. Shridhar,
Yeah.
it was a very informative talk. I just wanted to know what is the difference between the postgraduates who are taking help of your technology and actual training in the OT. So, have you made? Uh, are there any papers available comparing these two type of education?
Yes, there is papers from elsewhere, not from us yet, which shows decrease in the learning curve. What we have done is this anatomy modules we have created. Now, what we do is, this is a three-center program between Japan, India, and Singapore. What we are trying to do is, I'm doing a beta testing here now. So the residents learn the anatomy, then they go to the operating room, and we show them, you identify where is the Arrhenius ligament, tell us where is the round ligament, there is the right and left triangular ligament. We are creating the anatomy models for liver and pancreas, and they have to identify those structures, and we see what is the correct identification, the speed at which they identify, and there is a quiz afterwards. So that's how we are trying to compare traditional education versus using MR. So maybe in a year's time, we'll get the paper. Yeah.
And what about the intraoperative surprises and intraoperative mishaps? Does it go? It has gone down, or
Hard to say because, again, uh, what this allows is some degree of decision making, and but intraoperative mishaps, major mishaps are thankfully less, but the numbers that we'll need to see the difference will be huge. So the only thing we can actually look for evidence is the learning curve. But the hope is in years to come, we should decrease the intraoperative mishaps. That's the hope. But to design a trial for that purpose will be difficult to achieve.
thank you, sir.
Dr. Shridhar, are there any studies showing the impact of the VR and AR on patient outcomes?
Okay, again, my focus is mostly for hepatobiliary and liver surgery. There was a paper from China which talked about less blood loss and less operative time when they used VR in the operating room. Mixed reality, not VR. So they basically had the 3D images and the way that I had shown with the preoperative planning. But there was one paper, and the number in that each arm was not big. I am not convinced until the studies are replicated. But there is one study from China which looked at it.
So
So
I
I
think we
can't think
can
about operative
introduce.
time being reduced unless if it is a surgeon in training, probably yes. Yeah, sorry, I missed the question.
I think for education, it will be a very good. It is a very good tool. We can, because with increasing number of residents, the patient size is less. The surgeries are less for them. So
Yeah.
for education, we can introduce this. This will be a better thing. very good thing.
Yeah, I totally agree with that. I mean, that's where I see the immediate, and also there is a lot of mid-career surgeons who will want to jump to laparoscopic and robotic surgery, which they didn't have a option to train in their residency days.
Yeah.
So I think it is useful from that point of view, and that's a huge population that we are looking at.
It was a really enlightening lecture, sir.
Thank you.
Good.
Thank you. Yeah, so the company that we are working with, Apoclar, has now come up with a VR metaverse where you wear this device and you are in a operating room environment, and you can look at on one side you'll see the operating going on. Turn your head around, you'll see the scans. Turn your head around, then you'll see the histopathology of the frozen section, and you will have your colleagues standing there. So that's probably coming soon.
That's true.
But the only issue is the cost. That's why it's a
Yeah, but this cost will start to get less and less as time passes. It's just like the computing power. You get better stuff for lesser and lesser price now. So I think in 5 years time, you'll see that. At the moment, the HoloLens is very expensive. Apple Vision Pro costs about $5,000. Not affordable for run-of-the-mill work, because you can't give it to a resident and at one per time only one person can use it, right? And then if it gets spoiled, then again, repair costs will be high. But the cheaper versions of VR devices are available. But the problem with these VR devices, we need to create content for that. If you create content on the phone, that is the best, because the phone everybody has. That's why we are working with a company which creates content on the phone. There is an app you install, and within the app, there is like 500, 600 operations. You put the phone on the VR device and look at it at home. That is the easiest and the cheapest at the moment. But it's a subscription-based model.
Thank you, sir.
Thank you.
And thank you, panelists. And now, for vote of thanks, I request our Secretary Devorsi sir. So please.
Thank you, Vavar. It was enlightening really to hear what Dr. Shridhar had to say, and his vast knowledge, which has been shared with most of Amasians today, has been great. I thank you again, Dr. Iyer. I also thank the moderators, Dr. Prabha, Dr. Prashant Rahate, and Dr. Rajendra Mandia, and for your time. And thank you, Vavar, for convening this meeting. Thank you all. Thank you.
Thank you.
In the next
And a very good night.
Thank you. Good night.
Good.